Good morning, ladies and gentlemen, dear friends and colleagues. It is my pleasure to welcome you to this session on Ebola, assessment, treatment and prevention. Those of you that were at this World Health Summit last year will know how much it dominated our discussion and our thinking. And many of us, of course, over the last years have been heavily involved in the Ebola response, but not only the response, particularly also looking forward. And this is something we would really like to do in this session, to say, what now? How do we move forward? What have we learned? What needs to be done? And we have a fantastic panel here, which we will introduce to you as they speak. Initially, we wanted to start this session with a short film to sort of put us in an environment, at least virtually, in which the crisis happened. There's been some technical hiccups, and we hope maybe we can sort them out until the end of this session, and then we'll show you a short trailer at the end. But now it is my pleasure just to give the director of this film just a minute to tell you about it, because there is an opportunity to look at it later today. Please, Mr. Giersdorfer.
Thank you very much. My name is Kai Giersdorfer. I'm the director of the film. I hope it will be shown tonight at 8 o'clock in the evening at Kino International, and I hope there won't be any technical hiccups in the evening. I went to Liberia last year, and I spent 2 months on the ground doing the outbreak, but then earlier this year as well, we returned to Liberia, and in this film we took a strictly Liberian perspective. I really wanted to know how Liberian health workers, but also patients, experienced the Ebola outbreak. And we spent a lot of time in a place in rural Liberia called Banga, which was very badly hit by the outbreak. There was a treatment center there. And we went out with the Ebola ambulance where they were picking up patients every day. And then we followed 2 patients during the course of the illness. These 2 patients survived, 1 died. But there was also, we also looked at the social impact of Ebola, because the villages, Ebola sowed a lot of distrust amongst the communities and villages, because it was an invisible enemy that people found very difficult to deal with and very difficult to make sense of. And Ebola infected those that cared for one another. In Liberia, they always said Ebola was worse than the Civil War, because in the Civil War, you knew where your enemy was coming from. With Ebola, your enemy was your family, because they cared for the sick. You know, those that were close to one another got infected. And that led to a lot of social and psychological problems. And that's what we are looking at in this film on a very intimate and personal level. So the cinema will be almost full. The International is a big cinema, but there are, I think, 40, 50 places left. You will find some little cards, flyers out on the tables where there's an email address. If you drop an email or if you go on Eventbrite, you can still buy a ticket until 4 o'clock in the afternoon. So I'll be happy to welcome a few of you there in the evening. Thank you.
Thank you very much. I think for many of us it is very important to really have a visual understanding also of the things that have happened. And of course, in general, the media played a significant role during the epidemic, both positive and negative. But I also think in the aftermath of the epidemic, the media will or should be playing a very important role. Because, as we say, you know, we don't want this issue to fall off the political agenda. We want people to be concerned with the issues, with the mistakes, with the weaknesses of health systems and health governance around the world to really take these things forward. Just a word or two while I am sitting here chairing this panel together with my colleague from Pasteur, Jean-Claude Manuguerra. I was part of an independent panel that the member states of the World Health Organization put in place to assess WHO's Ebola response. There were 6 of us, and we were asked to look in particular at how WHO had responded or not responded, where it had failed, where it had done the right things. We issued a report in July of this year, which looks both at what the WHO needs to do in terms of restructuring itself, in terms of having a new kind of culture that can deal with emergencies, but we also looked very closely at what the member states of WHO need to do. The World Health Organization consists of the Secretariat, the experts, and its member states who take many of the decisions. And we saw very clearly that, particularly in relation to the international treaty we have in relation to health emergencies, the international health regulations, that countries had not fulfilled their obligations under these international health regulations. Countries had also not supported countries with weak health systems to be able to implement these regulations and to be able to care for their people when they do fall ill. And they have also not appropriately supported the emergency work of the WHO sufficiently financially to be able to move forward. WHO right now is in a process of reorganizing itself, and the member states will have to take a fair number of decisions, both political and financial, to move things further. There is also a discussion whether the international health regulations need to be revised under the experience of Ebola, but also, and this is something we will be speaking at this panel as well, is that the cooperation within the United Nations system, the cooperation with regional organizations, and in particular in crises such as these, the cooperation with the humanitarian system has to be much improved. So I hope that we will have some indications of all these points from our panel. There's also, of course, a big issue around science. What kind of research do we need in order to go forward in relation to neglected tropical diseases? And you know that the G7, particularly in the last 2 days also, with the health ministers and the science ministers, made an additional number of recommendations in this context. So I'd now like to hand over to Jean-Claude, my co-chair, to introduce himself.
Thank you very much, Professor Kickbusch. Yes, I'm here because my institute, Institut Pasteur in Paris, and its network around the world has been involved in this outbreak, especially our colleagues from Institut Pasteur of Dakar. They've been involved since the very beginning of the recognized outbreak in end of March. And although we did what we could to by sending people in the laboratory for diagnosis of the Masanta Ebola Treatment Center, which is still running nowadays, we thought that we needed to know more about the virus, about what it causes, and we needed to do more research on virology, immunology, vaccinology, and for this we set up, since the very beginning of the outbreak, task force at the Institut Pasteur and it's in the network. And what we want to do is try to make it carry on in the future, not forget it, because the outbreak is hopefully coming to an end. This is one of the reasons why we are going to set up a new institute in Guinea, in Conakry, and it should be operational in 2 years. So, of course, when we set up the task force, it was not to have results for this outbreak, but to have results and to kick a movement, a pace for the future.
Thank you very much. So we'll now move to our panelists. I'd just like to draw your attention again, particularly if you're asking questions afterwards, that all this is being webcast. So there's a large audience out there somewhere. And you heard from Professor Ganten earlier how many people are starting really to watch this from abroad. And this is a fantastic opportunity. We had initially invited the regional director of the WHO African office, Dr. Moeti, and she had agreed to come. But given a lot of political and other issues in her region, she had to move her regional committee. And therefore, she obviously has to be at the regional committee with her member states and could not come here, and she sends her apologies to you. She suggested to us her representative, Dr. Samba, who is with the Institute of Vaccine Development in Mali, had been involved in the Mali response to the Ebola outbreak, but in this case is speaking also on behalf of the regional office of the WHO. Dr. Sao, please.
Thank you very much. Good morning, everybody. I would like to thank the meeting organizer for having me here on behalf of WHO Afro Office. Dr. Moiti asked me to come and share some of the Ebola control experience with the panel and the audience. So I really hope that I will get into the main purposes of this panel during my talk. So WHO did play a key role during this Ebola outbreak in West Africa, but I have to say the main point of my speech is here to say that nobody was ready when this Ebola outbreak came in West Africa. WHO was not ready, UN was not ready, the ministers of health were not ready, nobody was ready. So it started in Guinea actually since 2013 maybe. Nobody knew that this was going on. So only in March they started to say, to formally declare this epidemic. And then Mali started right away the next day to set up our teams and to be ready. I would say that speed in responding, like just the next day after the formal declaration, was one of the key points to help Mali to better control this epidemic in the country. So we then started to organize ourselves and to be able to set up a team since we were not ready. And WHO and a lot of partners, UN, USAID, NIH, CDC, and MSF, Alima, I can't say the whole list here, but many, many partners joined the country to set up a very quickly rapid intervention team in the field. And then the government leaders, this is another key point, started to join very quickly, not only by staying in, at the capital city in meetings, but also they decided to go in the field to do a lot of visits. When I said government member, this includes the president of the country, who actually received phone calls from WHO, from the US president, from CDC, from many leaders around the world. So that helped to boost our national leaders to join very quickly the Ebola control team. And that way we started very early, by the end of March, to set up to strengthen our national routine surveillance system around the borders with Guinea. Because one weakness, maybe it's a strength also. When I come here, I have to show passports every morning, even by passing this gate here. So they have to take my picture, fingerprint. You cannot fingerprint Ebola virus when they come to countries. There is no border. When you go between Mali and Guinea, those of you who have seen, there is no border, there is no limit. Sometimes it's a good thing, but in cases like this, it's really difficult. So we started very early. This is the president of the country right here in the middle during some of the field visits with different partners. So himself, when crossing the border or when passing, visiting Ebola centers, etc., he has to wash his hands. So everybody will have to see that. So if the president washes his hand, then, you can't say, no, you have to do that. So actions like this help to better control, really, to have a community to change the community behaviors and beliefs into the Ebola control. And then that way we managed to quickly put our hands in the very first case coming from Guinea. You can see the route followed from Guinea, from the bottom, the little village in Guinea, coming all the way to Bamako, to Mali, and then cross the border around the second bullet green round in the middle. And then you see all those little dots, scared dots. These are the different villages, the taxis, taxi bus transporting this little girl, where the taxi stops, either to drop somebody or to take, another passenger. So we have to go in every single villages here to look for contacts. So that was one of the first actions that we undertook. And we then gather all those contacts together and follow them for 21 days. And when we were getting ready to celebrate the end of the 21 days and say, okay, we had one confirmed case. We managed to capture all the contacts. It's done now. The last day of the 21 day, we found another case. This is how the border looks like. When I said there is no border, you pass this one, the other side on our back here is Guinea, and here is this side is Mali. But just 1 meter away from this barrier, there is nothing. I mean, there are some families, your first wife is in Mali, your second wife is in Guinea. You spend 2 nights there, and then the next 2 nights you go there. And children cross the street every day, so there is no border. So this is the border control system we have. We don't scan passport. International health regulation, very important. This is it. It is so weak. It cannot be based on the routine public health system. We have to find a way how we can adapt and improve. When you pass the borders, that's the little paper you have, the first team you see, medical team will give you, showing that you have been seen, the temperature was taken, and you have no symptom, then you can cross the border. So when you reach the other side, then you have to show this. This is the proof that you've been seen. That's the only things we could do so far. And this is still some more challenges. There are a lot of challenges, but I'm trying to just mention here the key points. It was a very scary disease because we did not know about this disease in this part of the world. Maybe Central Africa knew, but West Africa did not know. Socio-cultural behaviors, very difficult to change our behaviors. Around funerals, when somebody died, we want to have a body, we want to touch it, we want to prepare it. And with Ebola, that was difficult to do. So we really have many, many problems with attitudes and practices in the communities. And during the contacts follow-up, one of the problems, lost to follow-up, and addresses. It was very difficult when somebody would give you their addresses. You go there for some reason, you can't find them. And it was very, very difficult to trust those cases, in addition to the rainy seasons and all the socio-cultural behaviors. So we have to have blessing from traditional healers. Socio-cultural people, they do not trust, they do not believe Ebola. And they are the ones who are treating every single, in case somebody is sick, this is the medicine, this is the vaccine, this is the antibiotics. So you have to convince those guys and make sure that they trust Ebola. In Guinea, I could say for Guinea, all those guys, like 90 to 95% of them died because they were in direct contact with Ebola cases. So the key here is to say, community is the key. You have to be in the community. You have to engage the community. You have to start with the community, continue with the community, and end with the community. So there is some research also around this Ebola outbreak. A lot of researchers going on. Some people want to do surveys, vaccine trials. So you have to convince, because people, once you start to take blood, etc., the second idea that will come is, they are selling blood. They give us Ebola. They'll give us HIV. They don't want us to live for a long time, etc., etc. So you really have to be in the community, with the community, and by the community. Involve them at every single step. Use local languages and local leaders. So that's the only secret. I would like to stop here. And thank you so much. Thank the meeting organizer for having me here. Time is so short. I have a lot to say.
thank you very We're trying to organize ourselves. So I'll say thank you very much also for giving us this really on-the-ground feeling and the things that really matter, both from the side of, really on the ground, but also you mentioned the importance of the political commitment of the leaders and the importance that they are seen to be fully involved and committed to fighting such a disease. We decided to move back and forth with introducing people, so we're still practicing. Okay.
Thank you very much. Now we have the pleasure to welcome Martial de Ikounga, who is Commissioner for the African Union in charge of human resources, science and technology. And he's going to now give a speech, and he's not on the page because it's the surprise of the day.
Good morning, everybody. I would have loved to deliver my intervention in French. Unfortunately, there is no interpreter, and therefore I try my best to do it in English, hoping that you will understand me. Let me begin by thanking the World Health Summit for inviting the African Union Commission, especially myself, to attend this annual conference. The Ebola outbreak in West Africa has highlighted the failing health systems in the affected countries, with significant deficit in human, financial and material resources that are required to provide adequate response to deal with the disease. These affected countries, Guinea, Sierra Leone, and Liberia, just recently emerged from war. The recent event in West Africa provided us with valuable lessons learned and a deeper understanding of Ebola virus disease. Indeed, this will shape our future preparedness and search for a cure. Regional actors have to promote crucial action that will enable member states to strengthen their preparedness and response for future outbreaks. I will mention a few. The Ebola outbreak was declared a threat in international peace and security by UN Security Council and public health emergency and international concern by World Health Organization. This demonstrated the linkage between health and security, peace and security. The Ebola outbreak was a global health concern, and it required the entire international community to double their efforts in improving global response and action to prevent future occurrences. 2. The failing health systems in the affected countries and other African countries should be strengthened through deliberate policies, including development and of the critical human resources and public health infrastructures. This will further improve surveillance system and laboratory capacity required for detection, control tracing, timely diagnosis, and treatment of the cases. There is also a need to promote collaboration and sharing the surveillance facilities and health network for infectious diseases. The African Union mobilized continental solidarity in coordination with bilateral and multilateral partners, civil society, private sector, and the media. We crafted a united comprehensive and collective African response to the outbreak. We created ASOA, an initiative for African Union support to Ebola in West Africa. We mobilized financial resources and deployed medical and public health personnel to the affected countries. We organized a number of meetings with the objective to assist the affected countries in their recovery and construction efforts, as well as global prevention of future outbreaks on the continent. To promote scientific research in Africa, the African Union Summit adopted a 10-year science, technology, and innovation strategy as a research policy instrument. Among its priorities, the strategy fosters prevention and control of diseases and promotes community to live together and build societies through research in social science and humanities with a view to influence behavioral change. We learned that the community engagement and cooperation were critical factors in controlling the outbreak. Furthermore, the head of state and government of African Union endorsed the establishment of African Center of Disease Control, CDC, as a Pan-African specialized technical institution that will work with member states in prevention, surveillance, detection, and response to public health emergency. It is important to note that there are two dimensions that must be raised at the research level. The first is the research in laboratories on microbiology, virology, chemistry, pharmacology, etc. And the second one, that is also very, very important, is all the human and social sciences that may allow us to better understand the spread and transmission of Ebola, as well as the fact that Ebola is one of the neglected poverty-related diseases, and also to catch how this virus can move from the deep forest and mutated within the highly migration population. Finally, all these international meetings, resolution made on Ebola, the expression of solidarity at national, regional, and global levels, and decision also not to isolate the affected countries and not to stigmatize the population, testifies that for all the world, the fight against Ebola become really a political issue. I believe that one thing to raise now, at least, is that beyond trade interest for research centers and pharmaceutical laboratories, one of our fight shall be to share data, expertise, experience, and lesson learned, so we can really win Ebola. Thank you very much.
Merci beaucoup, Dr. Ikounga, and thank you for highlighting again the political dimension, but also the sharing, that really we move towards understanding the sharing of knowledge, data, research, science, with a view to considering it a global public good. And many of the initiatives also right now from the side of the WHO include a roadmap for such sharing, for bringing very different kind of partners together to really be able to be prepared in terms of science and technology for any future outbreaks. But also thank you for highlighting the role of the social sciences. For me, it was always a surprise that people suddenly said, oh, we need an anthropologist here. Health is a social science, as we heard, and medicine is a social science, as Virchow said. And therefore, being interdisciplinary in our research for preparing for major outbreaks and epidemics is absolutely critical. We thought we would start this panel with people that really come from the region, that have really worked on the ground, that have really experienced Ebola heads-on. And therefore, of course, we are particularly pleased and happy that we do have a representative on our panel from Médecins Sans Frontières, the organization, the humanitarian organization that called the crises, that worked on the ground in an extraordinary way, that deserves tremendous kudos for everything it has done. But an organization that also has started to show us a way forward, the kind of things that need to be done between the health and the humanitarian system, that we can actually move forward. We have Florian Westphal with us here, who is the managing director of MSF Germany, and he will share experiences of his organization, but also some recent very troubling events that reflect on the humanitarian response in countries at crises and at war. Please, Florian.
Good morning, ladies and gentlemen. I would like to first of all thank the World Health Summit for organizing this important panel. I remember well when we met here roughly a year ago. The crisis was acute, hundreds of new infections every week in Liberia, Sierra Leone and Guinea, and really no meaningful international response in place that was up to the challenge. By now, the situation has significantly improved, even though we do have to remain vigilant until we really have no new confirmed cases for 42 days, and the Ebola epidemic can finally be declared over. Exhaustive analyses have been conducted to establish what went wrong last year and why it took the international community far too long to respond to this crisis. Different actors have been doing some intensive soul-searching, but whether any lessons have really been learned, we will only find out when the next outbreak strikes. If Ebola occurs again tomorrow in a similar setting, would we be any better equipped to help the patients and societies affected? At least, that's the question we ask ourselves at Médecins Sans Frontières. MSF has been playing a key role in the response to Ebola in West Africa. We treated roughly 1/3 of all the affected patients in different treatment centers. More than 5,200 confirmed cases. Tragically, more than half of them died, while nearly 2,500 patients recovered. 28 of our own colleagues were infected, and 14 of them passed away. Whether during Ebola or during epidemics elsewhere, we endeavor to work together with both national and international public health actors because we believe it's in the interest of our patients to do so. Let me outline some of the key concerns that we believe should be addressed and tackled jointly by humanitarian and public health actors. Ebola is only the tip of the iceberg as far as the human cost of epidemics is concerned, especially in low-resource countries. Every day, epidemics, such as the recent measles outbreak in Katanga province of the Democratic Republic of Congo, to pick but one, cause an unacceptable number of avoidable deaths. Yet, far too often, we see that epidemic response is not sufficiently taken into account when it comes to designing policies to strengthen health systems. The development of health systems and efforts to prevent epidemics are obviously vital, But the ability to actually respond to these crises must also be seen as a key indicator of the quality of a health system. We understand the need for good surveillance and laboratories, certainly. But if once the alert is launched, it still takes months rather than days to actually help patients, the problem remains. And let's face it, that is what happened during the Ebola crisis in West Africa in 2014. What we are calling for now is something that was sorely missing in the response to Ebola, namely the ability in the face of a sudden crisis to shift from a development mode to humanitarian emergency action. Ebola also presents a clear example of the flaws of the current research and development system we have. Some critical Ebola products, including the vaccine that now looks very promising in preliminary results, were stuck in the preclinical pipeline for years and could not move to phase 1 trial before the outbreak flared up. After the discovery and early research was done in publicly funded institutions, there was no economic case for private companies to invest into development. If the medical research system would put patients at the center of its concerns rather than profits, we could have had the vaccine even before the outbreak in West Africa, and a lot of lives could have been saved. As humanitarian and public health actors, we also have to look at what triggers international responses to crises like Ebola. We should be wary of viewing these threats through the prism of health security. Do we really have to wait for the UN Security Council to declare Ebola a threat to international peace and security before we take the actions necessary? Wouldn't it simply be enough to look at the facts on the ground and the fact that many people are dying without any viable response in place? This concept of security risks directing our focus towards concerns linked to the economy, trade, and border security, which are all important. But it's the welfare of the affected population that should be the main trigger for international action. Therefore, we at MSF advocate for an approach that aims to secure and improve the health of all, including the sickest in the most vulnerable societies, and that does so without discrimination. Ladies and gentlemen, with the permission of the Chair, I would like to briefly draw your attention to another crisis that is unrelated to Ebola, but of great concern to all of us who work in health. As I'm sure you know, in the early hours of 3rd of October, the MSF hospital in Kunduz, Afghanistan, was struck repeatedly by US airstrikes. 22 people died in these attacks, including 12 of our staff, and nearly 40 others were injured. The largely destroyed hospital had to be closed, depriving the people of northeast Afghanistan of the only facility there providing free, high-level life and limb-saving trauma care. This was not just an attack on a hospital. This was an attack on the Geneva Conventions, which were established to protect civilians and also especially the sick and wounded at times of armed conflict and those who come to their aid. Unfortunately, such attacks on medical structures, personnel, and on patients are a common feature in many of today's wars, for example in Syria, South Sudan, or Yemen. We did not just call for an international impartial investigation of the Kunduz attack because this is what the families and colleagues of those who died deserve. But we also called for that because in the face of repeated attacks on healthcare in wars, it's time to fight back for respect of the Geneva Conventions. So we are fighting back for the rights of our patients, and we need you, as professionals working in the health sector, to stand with us to insist that even wars have rules. Thank you very much.
Thank you very much. I think that they have nothing to add to this very eloquent speech. Thank you very much. So now we're going to listen to Maxmen, who is a journalist from the Pulitzer Center on Crisis Reporting and Amy is going to talk to us about the role of the global media in disease outbreaks. Please.
Hi. I thought I would start just by telling you about myself. Before I became a journalist, I was a scientist. I have a PhD in evolution. Once I finished, I decided to become a writer. So for the last about a decade, I've been writing for Nature, Newsweek, The Economist, you name it. And I cover generally science. But when I cover science, maybe because I'm from a science background, I realize that has everything to do with the scientist, the culture of the scientist, and the way that culture influences what's done and what happens and the results of things. And I think Ebola is no exception to that. When MSF was talking about this outbreak in around April, May of 2014, I was really interested because I had gone to Sierra Leone in 2012 to write for The Lancet about the free healthcare initiative in Sierra Leone. So I knew enough about the country to be interested, and I realized there were several factors about life in Sierra Leone that meant this could be a very bad outbreak. So what I'm sort of talking about is the way the dynamics of a place will influence anything in science, and that includes a virus. For example, when we had the Liberian patient in Texas, it's not just how Ebola is transmitted, but you have to think about what the healthcare system is in the United States, what the relationship between the CDC is and the Department of Health in Texas, what Texans are like. There's a lot of factors that go into how this thing may transmit. So at that time, I was senior editor at a magazine for science and culture, but I decided to leave in December with a grant from the Pulitzer Center. So I went to Sierra Leone for December, I was there for February, and I was there this past July and August. So the chair asked that I talk about culture, and that can be either the attitudes and beliefs that distinguish one group from another. It can also be the manifestations of human intellectual achievement regarded collectively. And I can speak to sort of both things. I'll start maybe with the second one, the one that doesn't distinguish us from each other. Because I think mainly, I wrote a lot of stories in Sierra Leone, but I think the main point is often, even though there are so many different customs and rituals, and Samba went through some of those very specific things that, with traditional healers that might be different from what we'll have in New York. At the end, often if you really trace what's happening, there's a human at the end of that. And I can name lots of examples, just to name one. This last time I was in Sierra Leone, I was talking with some British humanitarians who were talking about, there was one Ebola treatment unit where a patient had been caught escaping. There was a tarp fence around the Ebola treatment unit, and a patient had escaped out, and they said actually they had heard that healthy people had actually broken through the tarp into the Ebola treatment unit, which sounds completely insane. Then I talked to a Sierra Leonean doctor who sort of spelled that out. Well, can you imagine somebody's cousin falls sick, they take them to a hospital, they're put into this Ebola treatment unit, and their mother's never been able to say goodbye or is not able to see them. She can't see through that tarp that is opaque. And there's a very high likelihood that that person might die. And I can think about my own mom, and I'm pretty sure my own mom would break through tarp if that were the case. So sometimes I am afraid of talking about a thing that distinguishes one culture from another, because I think there's some very basic things about families and humanity in this outbreak. We talk about burial rituals, and I think there are all sorts of interesting burial rituals, and I've written about that as well. But really a lot of it has to do with showing respect for the deceased and being able to mourn the deceased in the right way. So if there's a way to talk with anthropologists and figure out how can those rituals be tweaked so that those basic things that happen around the world can still be adhered to, then that's what we want to do. But I also don't want to simplify it too much, because I think there's also, just to underscore how important communities are and culture is, it's not just, they're not the same everywhere. These countries, like every country, it's not a blank slate. I don't know Germany well enough to know how the North differs from the South, but I know it does in the US, and in Sierra Leone it does as well. And I think geography really points to culture in this way, too. So here's a map. It's from the World Health Organization. It's one of their situation reports just this past July. It's cut off. It's 2015. Dark blue is sort of the places that were hit really hard, and the orange and yellows, these are where there still was continuous outbreaks in July. So when you look at this map, so basically in the southeast of the country, they were hit very hard around, really amped up around August, September. But by October and then by November, once the international community had really started to show up on the ground in November and December of 2014, when the Red Cross unit was up and running in the southeast of the country, it's basically gone there. There was really no more Ebola by the time I got there in December in the southeast of the country. Meanwhile, in the western area, that's the capital, Freetown, that's lasted for more than a year. It was hit really hard, as hard as in the southeast, but it persisted for a long time. Same thing in the northwest. That's where up until just recently we've kept seeing cases pop up. So this is a clear case that there's something going on culturally. And you can think of little things like in Freetown, maybe that's no surprise. It's really dense. It's a disease of touching people. It's a very dense area. Okay, fine, that makes sense. Also, aspects of culture in cities. People are stubborn in cities. I was living in New York for a long time. So they're stubborn. In the middle of Hurricane Sandy in New York, people were walking around. Very independent sort of people that live in these places. Often they're outside of their community. It's not where they're from. So they don't have the same community structure that you might have in a place like the Southeast or the Northwest. And then comparing the two places, the Northwest and the Southeast, and especially I'm talking about like Port Loko and Bombali on the map. I'm pointing over there, but it's up there. They have the same density as the South, so it's not a question of density in those areas. And I can talk more about this. I wrote something for The Economist about it. It has a lot to do with those communities, who they listen to, the chiefs in the area, how the chiefs communicate with the medical people in that area. And ironically, the Northwest is the place that got most of the aid. So most of international aid happened in the Northwest. And that's also where the ruling party is. The opposition's in the Southeast. So this is a bit ironic that the Southeast got rid of Ebola. And this is all really just to say there's cultural factors there. It's not a blank slate. So when international aid comes in, it's not simply a matter of saying, let's communicate with communities. You have to have sort of a deep sense of what's going on in each place. And I think that has everything to do with talking with the people who live there. And then to keep it to move on, I spent most of my time when I was in Sierra Leone in the public health system. In Sierra Leone, that's the bulk of where people go, is the public health system. So we'll see pictures of like the nice white tents of various NGOs that were there, where it's white Ebola treatment units on concrete or on gravel, and they're pretty clean, they're well run. But if you go to the public hospitals, they were hit really hard throughout the outbreak, and they were in really bad shape before the outbreak. I mean, infrastructure-wise, without electricity and running water and too few staff. In Sierra Leone, there's 1.8 health providers for every 10,000 people. In the U.S., there's 100, so we have 100 times less, way too few to care for people. And so, for example, if we talk about a culture of not going to the health system, well, who would go to the health system? There may not be a nurse when you get there, if you can travel far enough to get there. That nurse may not have drugs to give patients. Maybe she's grumpy because she's been working 24 hours a day. And if she's not being paid, there's a chance that she'll ask for more money than what you think you should have to pay. So there might be some good reasons for also seeking a lot of traditional healing because there's not much of a health system to go to. So this is just a photo of the hospital that was down the street from the Red Cross's Ebola treatment unit. And along every wall, there's just flyers of all the health workers who've died. So it was already in really bad shape. And now they've lost many of their colleagues because early in the outbreak, they didn't have any protective gear. They were making aprons out of tarps that they found. And on top of that, when I was speaking to nurses about their experiences, and nurses were the ones who really had to bear the blunt of this because it's a disease you have to clean up infectious fluids. So they hadn't received their pay. And a lot of them told me that if this happens again, they definitely will not help. The heads of hospitals told me that why would they have faith that things would be any different, because they couldn't get the funds they needed in the public system before Ebola. So why would it happen afterwards? And that's it. So I have other stories. Thank you.
Amy, thank you very much, and for giving that feel again that we have to be very specific when we speak about community, and that communities are not only differentiated by whatever we might call culture, but there is also political dimensions of community and issues of power and resources that relate to communities. And we have to be very clear and precise. That's, again, which takes us back to the interdisciplinary kind of research and understanding. Thank you very much for making that tangible. Some of you might know that there's been a great influx, inflation, whatever one might call it, of Ebola response learning initiatives, that a number of committees and commissions and panels have been created to look at this. Some of them, as you heard, were created by the WHO and its member states itself. Others by coalitions like an assessment panel of the Institutes of Medicine in the United States. But there are also independent academics who have come together to say it is our responsibility also from academia to look into what has happened and to make suggestions of how to move into the future. One such initiative was created by Harvard University and the London School of Hygiene and Tropical Medicine with some other partners, and Suerie Moon from Harvard is here with us to give us an idea. The final report has not yet been issued, but to give us an idea of some of the concerns that our experienced academic colleagues have come up with. Please, Suerie.
Good morning, and first let me thank the organizers for having invited me to participate in this very important panel. I'm particularly pleased to be here in Germany, and not only in Germany, but at the Ministry of Foreign Affairs, because I believe the German government has played a very important role, a leadership role, in helping us to reflect on a number of the important global governance challenges that Ebola has raised, specifically around the role of the World Health Organization. So I'll come back to that point later in my remarks, but I just wanted to flag that I think that's a very important contribution, certainly that has been made by this government. So just a few words first about the panel. I had the honor and the pleasure to be the study director for the Harvard LSHTM panel that Ilona just mentioned. It's a panel of 20 independent experts coming from academia, from civil society, from think tanks. And we came together to examine what were the greatest sort of weaknesses that were exposed by the Ebola outbreak, the greatest weaknesses in the global health system, and what might be done to try to strengthen some of those weaknesses. And I am not able to share with you yet the specifics of our recommendations. Those will be published in a few weeks' time in November. And I hope that you'll all take a look at those. But I did want to share a few reflections from the deliberations of the panel. So let me begin first by saying that certainly we were very impressed and admire the many, many thousands of acts of courage and sacrifice and solidarity that were displayed during the outbreak. And I think you've heard about a number of those acts from some of the other panel members. Despite what I think was a very impressive mobilization of human solidarity, we certainly cannot escape the conclusion that Ebola also exposed that we have a global health system that is extremely fragile and in many cases broken. So what can we do to try to make sure that the system is stronger the next time around? That's what I'd like to focus on. Of course, at the national level, it's communities and local and national governments who are the first line of defense for any disease outbreak, and national health systems and adequate investments in those health systems are certainly critical. But when a single government is unable to handle a crisis alone, or when an epidemic hits more than one country at the same time, as occurred during Ebola. Of course, there is a very important role for the global community to play, or what we call the global health system. And the global health system needs to be that second and sometimes third line of defense. There are at least 4 key functions that the global health system must be able to do in response to outbreaks. First is, of course, to try our best to prevent them by ensuring that there's adequate investment. Second, to ensure that external aid is mobilized as quickly and as effectively as possible in response. Third, the critical and important role of knowledge and research, not only the generation of knowledge and research, but the equitable sharing of knowledge and research and the benefits of that research. And finally, stewardship. And stewardship is a topic that I think too often doesn't quite get enough attention in our discussions of what is important for the global health system to be able to deliver. So I'd like to leave you with just 3 key points. First, governance matters. Why does it matter? Are the low-hanging fruit. That's actually what's easier to put on the table. What we also need to figure out is how to make the overall system work better. And this is what I mean by governance matters. And what do I mean by governance? What we need is clearer rules. We need clearer roles and responsibilities, and of course, measures to ensure that there's accountability for the fulfillment of those roles and responsibilities and for adherence to rules that have been agreed upon. And so far, we haven't yet been able to tackle some of these governance challenges. Let me be a little bit more concrete. What do I mean by this? When we talk about rules, we need to ensure that, for example, governments are not closing borders and isolating countries that are hit by outbreaks. We need to ensure that airlines and shipping companies continue to operate into regions and don't make the international response even more difficult to mobilize, as took place, unfortunately, last year. So we need adherence to the rules that were already agreed by governments that they would not, in fact, put in place unnecessary or scientifically unjustified trade and travel restrictions. We also need, for example, not only to have research done, we had research mobilized in record time. It was a very impressive collaboration between a number of actors, public and private. But we need that research to be done in a coordinated fashion, and we need rapid, real-time sharing of information. And that was also something that was not done during the Ebola outbreak. Finally, there was a huge amount of money that was mobilized. I think we can be very proud of the generosity that was displayed by a number of different actors, again, both public and private, an estimated $5 billion mobilized in record time. But it's still unclear exactly how much was not only committed but actually dispersed. It's unclear to whom all of that money went, how well it was spent, and what were the impacts or the outcomes of that spending. So there's a need certainly for much more transparency and much stronger mechanisms for accountability for the way the entire global response was run. So these are just a number of the key governance questions that I think arose. Let me get to my second point regarding WHO. WHO has certainly taken a lot of criticism over the last year regarding the weaknesses in its response, and there were many, many other actors who played an incredibly important role and sometimes did not perform as well as we would have liked. But certainly many, many different actors involved, from national governments, UN agencies, non-governmental organizations, private foundations, private sector firms, journalists, social scientists. There were many, many different actors involved. So why focus on WHO? The reason I focus on WHO is because it's absolutely central to the global health system. And it's central not only for the operational response. Much attention has been given to whether there were enough WHO staff on the ground, whether they had the right expertise, whether they had enough money to respond quickly. These are very important questions. But there are many other functions that WHO plays in the system. For example, WHO is responsible for alerting the international community, including through the declaration of emergencies. Not only that, but certainly including that. WHO is responsible for ensuring adherence to the international health regulations, for demanding respect for the international laws that have already been negotiated and agreed upon by all of its member states. We believe that WHO is responsible for putting the protection of public health before the narrow interests of any particular member state. And certainly WHO should be able to take the best technical decisions without being unduly swayed by political considerations. And I think in all of these areas, unfortunately, what we saw was that WHO was not ready to perform these functions. So certainly a number of the changes that will need to be made going forward will have to do with money and with more people, but they also need to address these deeper systemic and structural challenges. Let me conclude with my last point regarding leadership. And taking forward a number of the recommendations that we will make, and of course the other review panels that have been convened will require high-level political leadership. And when we talk about high level, what we're talking about is heads of state. And that's why, as I said at the very beginning, I'm very pleased to be here in Germany, where Chancellor Merkel has played such an important role, not only in addressing the Health Assembly earlier this year, but in making this issue a central part of the agenda of the G7. We understand that Japan, as they take over the leadership of the G7 next year, will continue putting important emphasis on this, on the issue of global health security. But finally, I'd like to emphasize that it's very important to have high-level political leadership from both the North and the South, not only from the G7, and that these are issues, the governance issues are ones that will take a long time to address, and that structural issues are more difficult than just putting more money on the table. And so I hope that there will be adequate attention and adequate political commitment from the highest levels of leadership to make sure that the system is stronger the next time around. Thank you very much.
The moon, you very well illustrated the basis of the creation of GORN. We haven't talked about GORN yet, but I think we will in the discussion, because it's an important player coordinated by WHO. And one of the bases of its creation is the problem somewhere is headache for everybody elsewhere. So that's why you illustrated the global aspect of crisis. So next speaks, last one before questions, is Wien Leereveld. I hope I didn't say it too badly. And you are the CEO and founder of the Access to Medicine Foundation, based in the Netherlands. And the topic of your talk is how to strengthen research for neglected tropical diseases. So please.
Thank you very much. Let me say, I take this opportunity to tell you that I'm very proud here at World Health, to be here at the World Health Summit in Germany, especially Germany, because I really admire Angela Merkel's and Germany's role in the refugees. We can all learn from their attitude. Okay. Can we prepare for new infections we know nothing about? That is the question. And it's all, I think what I want to discuss is incentives. A lack of incentives. The recent Ebola outbreak is a reminder of the limitations of a system, of the current system, of incentivizing pharmaceutical research and development for diseases that disproportionately affect low and middle income countries. Yes, there was the technology and the know-how to develop effective vaccines. Candidates existed, but simply the incentive to invest in and the push these through were not there. So that's why I'm here to tell you something what I think what we could do as an incentive, what we could create. The last words I'm going to say that yes, there will be an access to vaccines index coming out next year from my organization, and I tell you what we then, how we structure that, and why does it matter? First of all, I think we should also cooperate together to address all these challenges, and cooperate also with the private sector. I knew the private sector from during my life, and at a certain stage, I thought, and that's the word I often use, they need help to help us, and that's how I look at it, because they simply don't know how. But they are strong enough, and they are at the moment willing. So I looked at this matter as, yes, we created access to medicine, so for 5 billion people, let's treat this matter constructively, 2 billion to go. So let us not think of blaming or shaming, or let us not find out why or what went wrong. It's just 2 billion to go. So what can we do? What is the hurdle to get all parties at the table? It's simply that there's no common agenda. That is the problem. Because, for example, in patents, Oxfam, MSF have perhaps different opinions than, for example, the World Health Organization. And if you look at local governments, representatives from local governments, you get another opinion of these details of access as well. Like, for example, if you approach the pharmaceutical industry, perhaps they have an opinion as well, or perhaps they're investors. So when I entered this scene, I think it's now 13 years ago, I saw, the industry is simply not able to listen to all of us, simply because we have not one voice. So could we create, that was the question, could we create a model to hold these companies into account? Is that possible? A model for research and development, for pricing, very difficult issue, for how they do donations, how they enter these markets. I mean, for example, bribery issues. Do we know what we want from them, and can we unite in that? This model we used for the last Access to Medicine Index, which was published in the end of 2014. And it's not we that decided this model, it's already a model that's developed during the past, I would say, 8 years. Companies had some say in that. In fact, the last say, they didn't change very much from what civil society, World Health Organization, governments, they were all informed, people from Harvard, they were all involved. And this is the model, yes, it was possible if you put everyone at the same table, and not individual companies. We invited the International Federation of Pharmaceutical Association at the table to have one say, and this is the model that we now measure the 20 biggest pharmaceutical companies worldwide. They had no role in development of this index. In fact, it was a little bit a surprise when it appeared in 2008 for the first time in the Financial Times. Because some companies heard about it, but companies at the first moment, they didn't want to cooperate at all. They thought it's another attack on them. So we just organized this model outside the pharmaceutical industry, and we confronted the industry with this. And today realized that all companies, all 20 companies cooperate. They all gave their data, realized that from zero, they're not willing to give any data. Now they are, I would say, 180% giving their data, almost everything we ask for. For example, for pricing, very sensitive information, they're willing to give it only under circumstances of non-disclosure. So I can look into their business, but we are not allowed to tell you individually. We can make analysis and we can advise them individually. And that's what we do today. We have a role, with this index, we grew into a role that many leaders of these companies today think, well, this makes sense. Because I must say to you, this is not only a matter of social behaving, but also business. How far are these companies in developing their markets, the southern countries? I go one step further. And this is interesting slide because yesterday I was at a party at Allianz. And I think that was the first investor that I saw. The investors in the big pharmaceutical companies are not here. And that's interesting because I sometimes visit investor meetings. And yes, they are willing to play their role because health, also for them, is a very important issue. It's a reputational issue. It's a risk issue. And, without health, their business is also not very healthy. So, yes, these investors signed our investor statement and they are willing to softly press these companies into the direction of that the index sets. So first we find out what do we want from these big pharmaceutical companies, also on vaccines. Secondly, we measure company per company and we share that with you. So it's there, it's a big book. It's about 106 countries where we measure. And today, let me say that also the investors are going to play a role. And what I want, I'm going to discuss that perhaps in iteration of this Congress, I hope to see a bit of more of these investors who are willing to play their role and also have an effective role approaching Big Pharma. So it's the money behind Big Pharma. This is my time. This is the last index. This is the 2014 index. Do they care? I tell you, yes. These companies really care. They compete with each other. You look at the bottom of the index, the Japanese companies, they doubled their scores in the last index. They set up partnerships addressing neglected diseases. I tell you that if you ask around for the pharmaceutical industry, they will tell you, yes, we really care and we really developed our projects. I hope to tell you in the next iteration of this Congress how we measure these companies on vaccines. And then you see that Ebola is an issue. Thank you very much.
Thank you very much, Wim, and thank you for drawing attention to the fact that when we discuss these issues, we talk about an enormous health economy. We talk about a global industry that is one of the largest in the world, and that is not only defined, as you rightly said, by the companies we usually look at, but actually is a major area of investment. And we see that, of course, in the area of pharmaceuticals, but we clearly also see it in the NCD-related areas where, because they are such major areas of growth, key equity firms are obviously investing in tobacco, in alcohol, and in unhealthy food. So these markets expand, and therefore we have to reach out to the investors. I think that is a very important point. We decided in preparing the panel that right after the presentations, we would open up to you. We would collect a number of comments or questions, which we hope will be short. And then we will give it back to the panel for some responses. So please raise your hands if you have something to say or something to ask. It's hard for me to see, but I have some help here. Right back there, okay. And please introduce yourself.
Thank you for the very interesting remarks we've heard so far. My name is Jonathan Baum. I'm a fellow of the Mercator Fellowship on International Affairs. And my question is, I think, to Mr. Westphal and Professor Moon. So we've all heard about the different initiatives that are going on now. One of that is the White Helmet Initiative, which was also launched by Germany. And on the European level, this is now turned to the European Medical Corps. And I would like to know what you think of that. Is it really a suitable tool for future outbreaks? And second of all, do you think that the political drive will also be sustained in the coming years? Thank you.
Thank you. May I collect one or two more if there are? Yes, please. We have these lights shining in our face, so I don't see you that easily.
Thank you. Thank you very much. My name is Dr. Ngozi Azodo. I'm the Director, Health Plan Research and Statistics for the government of the Federal Republic of Nigeria. First, I want to, on behalf of my government, thank the WHO and the international community for the kind of support Nigeria got during the Ebola virus disease outbreak in Nigeria. Then, going to specific comments, I think some of the things that have come out here, which I need to emphasize, is the need for a command structure that aligns behind a government when there is an outbreak such as the Ebola. Then there must be transparency and accountability. Because what helped us in Nigeria, we had the highest political will and commitment you could ever require. We had a command structure and there was transparency. Everybody in Nigeria was waiting to hear what the Minister of Health would say. And so every morning at 8 a.m., there was a press briefing. The minister was honest, he was open. If there were problems, he said so. He told Nigerians, we are going to come back to you. When somebody dies, he also said so. We must encourage governments to come to a point where it is not a failing necessarily that somebody has died. However, not being able to tell your people the truth is the failing, so that everybody will be open and transparent, and then people will begin to trust their government. And that's very important in Ebola warfare. Now, going forward, some of the things we may need to also reflect as part of our control measures is the impact, the economic impact on healthcare providers, and begin to make provisions for that. Now, can you imagine what would have happened if a private health facility in Lagos knew that there was going to be a problem and just hit the fact that there was an Ebola case? And of course, even though the government knew and was working with them, before a confirmation could be made, a lot of damage could have been done. But if facilities know that, yes, there is a problem, there will be some kind of cushioning for a business like a private hospital, a private healthcare provider, it becomes an important element in ensuring that people are open, they are forthright, they are upfront with whatever diagnosis they make. And that's because across Nigeria, for instance, and I'm sure in most African countries, private care providers are many. They account for about 50% of the health service in the country. And a lot of them are not very big businesses like we saw in Lagos. So the fact that there is a commitment on the side of government to ensure that there is provision for whatever economic losses they may suffer will give people the comfort to come forward and be honest and be open and be forthright. So I think it's something that the WHO and other technical partners need to also begin to speak about. Thank you very much.
Thank you. Is there one more question or comment?
Can it be a short comment?
From yourself, of course.
No,
over there.
The question can be short.
All right. A short one, and then we'll move back to the panel.
Thank you very much for your different presentation. I'm Francis de Vreecourt. I'm a professor of management science here in Berlin, so nothing to do with medicine, even not healthcare. But I want to go back to the beginning of the Ebola epidemics, when MSF was screaming for help, and WHO waited till August to declare an emergency, a global emergency. And I guess surely everybody had the same data at that point. I mean, everybody was seeing the same thing. And yet came to different decisions or conclusions on what was really happening. So my question is simple now, after many months after the earlier of the outbreak, what really happened? How come WHO didn't see what MSF was seeing on the ground? So what really happened during those early months? Thank you.
Thank you. So let's get back to the panel. I think there were a number of questions that all panelists want to reflect on in one way or the other. The first one was very concretely to Florian, Westphal, and to Suerie, but you might want to take up issues of the last comment as well. Please.
Okay, yes, just on the first question, indeed, on the White Helmet Initiative, I think the first thing that needs to happen is that the name needs to be changed. Medical staff don't wear helmets. They don't need helmets. And I think to call them helmets actually sends a totally misleading message, which potentially on the ground could create a lot of problems and misperceptions amongst local communities. Secondly, I mean, I think it's true that what we were calling for was additional capacity, and because the situation was so desperate, we left that fairly open, whether it was military or civilian capacity, to help and to come in and to treat patients at the height of the Ebola crisis. So clearly there was an indication that, internationally speaking, there was not sufficient, literally, people who were trained and briefed and prepared for this kind of mission. Having said that, I think there are two things. First of all, obviously, that can't just be an international effort. I mean, clearly there needs to be a parallel investment into national capacity to contribute to this kind of response. And secondly, the important thing is, again, what would trigger this white helmet, or whatever you choose to call them, what would trigger their action, actually? What would bring them into action? Would it be a political decision, which is taken when the countries that in a way finance and organize these kinds of initiatives feel that an epidemic may present a threat to themselves? Or would it be driven by the straight-down humanitarian imperative of patients' needs? If we look back at the crisis last year, and if we'd had that kind of thing in place, the timing of the response would have been very, very different. Will the political interest be sustained? I mean, I can only answer for Germany. I think there is a noticeable political interest by the German government, and I certainly hope it will be sustained. We will certainly try and exert every means of pressure we have at our disposal to encourage the government to keep its interest in global health issues generally, but also more specifically in the types of issues that were also highlighted in the G7 summit declaration.
Suerie.
Thank you very much. Thank you for the questions. I'll try to respond very briefly to, I think, 3 points that were raised. First, regarding what's been called the White Helmets proposal, or the global health workforce. I would agree certainly with Florian regarding the need for a name change. And I think it has certainly huge potential to provide the key human resources that are required. But one of the key conclusions that we have reached among our panel members are those types of measures alone will not be enough. Second, regarding the question of political will, which is of course related to the longer term and sometimes more difficult structural changes that are needed, we certainly hope there will be sustained political will. There have been important acts of leadership, as I mentioned earlier, but there's certainly no guarantee, and there are no shortage of pressing other issues, the refugee crises in Europe, certainly the recent bombings in Afghanistan, all of the war in Syria. There's no shortage of other important issues. I think the way to sustain political attention to the changes that are required post-Ebola is for civil society and for students and for academics and journalists to really push their political leadership to make sure that they do not forget and let this slip down the agenda. Lastly, regarding the question on emergency declarations, certainly that was one of the most visible signs of a broken or a WHO that was not fit for purpose. And will signals from MSF or other actors on the ground be listened to next time? I think one of the key changes that we need to think about very seriously is how do we change the system for emergency declarations so that it is more robust, less open to political influences, I should say, and it is credible and trusted by the international community. What are the types of information that we need and the other types of institutional arrangements? And we certainly have one of our 10 recommendations addresses precisely this point. Thank you.
Thank you, Suerie. I might add that our interim assessment panel also was concerned with the different levels of declaring a public health emergency of international concern. We felt that the triggers had to be made very clear, because once you declare something, something has to happen. And I think one of the weaknesses, or we thought as a panel, of the present declaration of such a FIC, as it is called, is that it does not really trigger a systematic a consequence of actions, either in terms of political action, resource-based action, workforce-based action, etc. And we also felt that we need to focus much more on the fact that we don't want a FIC declared. We actually want everything else to be in place before, so that we do not need to move towards a FIC. And therefore, we also suggested that there needs to be an intermediate level that actually generates the kind of political and other support that is necessary. I now want to go back to Dr. Sao and Dr. Ikounga to give us the perspective from the African region and the Commission. Please.
Thank you very much. I just would like to echo what the previous speaker said. I started my speech by saying that what we learned from this Ebola outbreak is really, the first thing was that nobody was ready, including WHO, including countries, including UN, everybody. Even MSF was not expecting such a large epidemic in West Africa, in countries like Guinea, for example. So having said that, we learned, there are lessons learned. So WHO didn't declare formally this crisis early enough, but at country level and local level, WHO country representatives were working very closely with ministers of health and government. So sometime at the country level, the message was not getting there on time. And sometime also when WHO country office has to take, the administration, the system is so heavy so that by the time it gets to the target, it really takes time. And number two, I think international health regulations. There is clearly a need, as you just mentioned, from this epidemic. We need to sit down together. We now know that the world is, just one thing. We all need to come together to control diseases like Ebola. When Ebola started in Guinea in March, it was imported already to the United States before coming to Mali. There is no border between Mali and Guinea, but it went from Guinea all the way to US before coming to Mali. So there is really no border around the world for pathogens. So we need to review the international health regulation system and adapt it in a more practical way so that we will be able to early enough handle situations like this. So this is part of the lessons learned. I fully agree with you that we need to review the system and improve the system from this thing. One last comment from the private sector. I fully agree with colleagues from Nigeria who mentioned the private sector. So this private sector includes modern medicine and socio-cultural traditional medicine as well. So we need to work closely with them. They have to be part of the national health system because this is the first level where somebody is sick in the community where they will go to look for care. So I fully agree with that comment also. Thank you very much for this. Sorry for being long.
Yeah. Thank you very much for that conclusion. We've been told that time is pressing. We do have the trailer of the film, though, so we are going to show it. Those of you who still want to see it, please stay in the room and watch it. You will get a feeling for the film. We would like to say, Jean-Claude and I, a great thank you to this extraordinary panel. I think many of the key issues that we need to deal with as we move forward have been touched upon, and I don't think this is the last time we will discuss the implications of the Ebola crisis. I hope next year at the World Health Summit we will be able to see some concrete new mechanisms put into place at the international, at the national and the local and the regional level to be able to deal with such crises better. Thank you very much for your attention, and please thank the panel again.
I get in a field, get patients from a house that there's no family left in that house. Ebola have taken everyone away. Got me afraid, but sitting home could not solve my problem. So I decided to join the fight.
I came to help because this is our only family members, friend. So we won't sit back and watch other people come and then do this work.
I pray God I stay safe now. I'm not thinking about my children now. And my better family that me.
There are people in a town, they are blaming. They say, all the cause of their people to die. I'm scared to go there.
The Civil War was much more better than the Ebola War because they knew our enemy. You see a group of soldiers coming and you hide yourself. But the Ebola, you don't know what direction Ebola coming from. You see, that's the story.